Hey guys, I'm going to try to record the prologue responses as often as I'm able to in order to try to make this a little bit more streamlined for you all. Let me know if this is helpful or if you just prefer the slides alone. We can also do this for the practice bulletin summaries that we hopefully will be able to send out, and also like the mini lectures. And so there are two questions in the first prologue quiz series. So question one had to do with endometriosis management, particularly for women who have failed both, traditional surgical excision and or hormonal management, and they now are at a point where they desire definitive management in the form of a hysterectomy and BSO. Ovarian conservation is associated with treatment failure for these women, and so it's important to remove their ovaries if they really do have such extensive disease that it's requiring definitive management. And so in the prologue series, they talk about the benefits to women when their ovaries are removed in terms of the decreased likelihood that symptoms will recur. And so 61% of women have a chance of symptom recurrence if the ovaries are left in place. This is six-fold higher than women who have received a BSO. There is also a very high chance, 31% chance of future surgery over the next 5 years if the ovaries are left in place, eightfold higher than women who have received a BSO. However, the downside of eliminating estrogen is that estrogen is important, as we all know, for young women. And so in women less than 40 years old, losing, having a very low level of estrogen, leads to poor physiological outcomes compared to women who experience more physiological menopause between the ages of 49 to 51. And so they're at increased risk of bone loss. They're also at a much higher rate of death from ischemic heart disease. And then not to mention, they have to deal with, menopausal symptoms, which are not fun. And so the bottom line, treat these women with estrogen. Even if you treat them with estrogen, the rate of occurrence is less than 1% per year. So this is, and this rate they anticipate is going to be lower in women with a complete excision. And then remember, estrogen is important for both bone and heart health in women. So now moving on to question number 2. So question number 2 has to do with treatment of bacterial vaginosis. As we all know, BV accounts for a large percentage of cases of abnormal vaginal discharge, in our patients that we see in clinic. You diagnose BV with Amsel's criteria, so let's do a quick review. So the presence of at least 3 of the following. And so the first is that homogeneous, thin, grayish, white, funky smelling discharge, elevated vaginal pH 4.5 or higher, a positive whiff test on a wet prep. This is using 10% potassium hydroxide, and greater than 20% of the epithelial cells are clue cells. Just know that for women who with recurrent BV, also remember to screen them for STDs. It's okay to treat these patients in particular if they're asymptomatic. However, you wouldn't treat, in general, an asymptomatic woman who, for example, has a positive BV that came back on a pap smear. And so I have this little cartoon here, just to remember that, the vaginal pH is typically, 4.5 or less. However, if you get too high, that puts you at an increased risk of infection, and that's what you see when you have bacterial vaginosis. And this is a little cartoon of clue cells, so you can see all the bacteria lining the epithelial cells under light microscopy. So what are the treatment options? This was a question that I felt like was very random, but I learned something. So typically we treat BV with metronidazole, You can give 500 milligrams BID for 7 days. That's what I typically do in my clinic. Metronidazole has an 8-hour half-life. Now, there's this new medication called secnidazole. This is a second generation 5-nitroimidazole. It has a much longer half-life, about 17.5 hours, and you can give as a single dose of 2 grams. In the practice or in the PROLOG question answer, they say you can mix it with applesauce to make it better tasting. And this medication has been shown to be superior to placebo and approximately just as efficacious as Flagyl. So they have, compared to Flagyl at 28 days, the clinical cure rates are 77% with secnidazole versus 79.3% with Flagyl. So Flagyl is slightly more efficacious, but given that this medication seems to be much easier for patients to tolerate, it might be in an acceptable compromise. When you look at clinical plus bacteriological cure, they're almost neck and neck. So it's hard. There's really no clinical difference between those two. And then just kind of one important fact, when to consider suppression therapy for patients. You should do that if your patient's experiencing 3 or more documented episodes within 12 months. That's why it's important to have people come into clinic and actually get the diagnosis confirmed, to not prescribe medication as often as you can. Avoid prescribing it over the phone. Until coming soon, hopefully, we'll be able to do a review on endometriosis and also a review on vaginitis.